शेयर किया, देख लो, शेयर किया। एक मिनट। Good morning, everyone. Today, I am here to present on the drug Vortioxetine. Vortioxetine Brintellix is a FDA-approved drug used for the treatment of adult with mood disorder, approved on September 30th. Hypothesis: the mechanism of action. This is a hypothesis. The blockade of secondary serotonin reuptake, but pharmacologically different from other SSRI because it works by direct modulation of various serotonin receptors. Vortioxetine is an antagonist of 5-HT on presynaptic neuron, which accelerates the antidepressant effect similar to Pindolor, which is a SERT blockade high affinity, which has SERT blockade high affinity. Act as an antagonist at 5-HT3, 5-HT10, and 5-HT7 receptors. Agonist at 5-HT1A and partial agonist 5-HT1B of multiple serotonin receptors. Now, the color of the tablet available. There are basically variable colors of the tablets which are available. These are pink, orange, yellow, red. These are based on the dosage of the drug. Oral films coated tablet, color is based on the strength. Indication and dosage. Starting dose starts from the 10 mg per day and which goes on increasing up to 20 mg per day. It can be discontinued abruptly. Pregnancy category C, it is the indication. No data on breastfeeding. Drug interaction. Increases risk of serotonin syndrome when used with other serotonergic agents. We should avoid SSRI, SNRI, tricyclic antidepressant, triptans, MAO inhibitors, linezolid, methylene blue, and lithium. Abnormal bleeding when taken with NSAIDs, warfarin, and heparin. Metabolism is by cytochrome P206, which has inducer the 5 times the maximum recommended doses, and inhibitor doses decreases to half. Negligible effectiveness on cytochrome's enzyme. Pharmacokinetics. Onset of action 2 weeks and oral bio availability 75%. No effect with the food. Time to peak plasma concentration is 7 to 11 hours. Metabolic pathways are cytochrome 2D6, cytochrome 2A4/3, cytochrome 2C19, cytochrome 2C9, cytochrome 2A6. Half-life is 66. Protein binding capacity is 98%. Elimination is by urine, urea and feces. Urine counts to be 59 and feces is 86. Up titrate is 20 mg per kg. Down titrate is 5. Now the areas of the drug Vortioxetine, which can be categorized as mild and serious. Mild includes nausea, constipation, vomiting, headache, dry mouth, dizziness. And the serious reactions are hypertensive crisis, increased risk of suicide, pancreatitis. The sexual side effect which is seen is more common in men than women. Contraindication of the drug Vortioxetine. Contraindication when using MAO inhibitors and linezolid. Vortioxetine, the drug is stopped and MAO inhibitors prescribed within, and MAO is prescribed within 21 days. Once MAO inhibitors stop, Vortioxetine cannot be initiated in 14 days. Thank you.
Morning, everybody. My topic is Clozapine. The introduction to Clozapine. It is the first second generation antipsychotic which was discovered in 1905, five-membered heterocyclic compound. Good morning, everybody. My topic is Clozapine. Introduction. It is the first second generation antipsychotic which was discovered in 1958. It consists of five-membered heterocyclic compound and the chemical formula is C18H19N4Cl. Clozapine is available only in oral preparation. It attains peak in 2 hours after oral administration. Elimination half-life is 12 hours, because of which it twice daily administration results in steady state plasma concentration in less than a week. Undergoes first pass metabolism in liver and gut. Metabolism. Metabolism takes place in liver and gut, and bioavailability after ingestion is 27 to 47%. Metabolism takes place through demethylation, N-oxidation, oxidation of aromatic ring, and conjugation. The metabolite formed after the metabolism of clozapine is N-desmethylclozapine. This metabolite is a major contributor to clozapine's effect on cognition and negative symptoms. The metabolite binds with M1 receptor. The mechanism of action. Clozapine binds weakly with D2 receptor and blocks it with strong affinity for 5-HT2 receptor, which again it blocks. Low dose affinity for D2 receptor causes less extrapyramidal symptom, and thus it makes it different from first generation antipsychotics. Lack of extrapyramidal symptom is due to fast dissociation from D2 receptors. It also has 10 times high affinity for D4 receptors, which are placed in cortex of brain. This is the diagram showing difference between the affinity between 5-HT2A receptors and D2 receptors. It has high affinity for 5-HT2A receptors, while it has low affinity for D2 receptors. Dosage and administration. The dose begins with 12.5 to 25 milligram per day, which is increased to 25 or 50 milligram per day on the second day and subsequent. Target dose is 300 to 450 milligram. 5 milligram per kg daily dose is equivalent to plasma concentration of 200 to 400 milligram per kg. Blood concentration, in women it is found that the concentration is higher. In smoker, it is found to be 20 to 30% higher, whereas in adults, it is found to be two-folds higher. Uses of clozapine. It is used in treatment of resistant schizophrenia, acutely psychotic patient, tardive dyskinesia, reduction. It also helps in reducing the risk of recurrent suicidal behavior in schizophrenic patients. resistant mania, severe psychotic depression, and neurological illness, such as idiopathic Parkinsonism and polydipsia, hyponatremia syndrome. The contraindication of clozapine are when it shows hypersensitivity, when patient shows hypersensitivity reactions to clozapine, when WBC counts are less than 3,500 cells per mmq, previous any bone marrow disorder, history of agranulocytosis during clozapine treatment, concomitant use of any other bone marrow suppressant drug, respiratory depression is seen in patients who are when the clozapine is given with any other benzodiazepine. Black box warning. The first black box warning is agranulocytosis, the risk of which is 0.73% in first year and 0.07% in second year. Agranulocytosis is a fatal condition that requires immediate medical attention. Risk increases with age and is higher in women. Thus, clozapine monitoring system is important. The monitoring is done first weekly for first 6 months, then every second week for second 6 months, and finally monthly for next 12 months. Orthostatic hypotension likely to occur at early treatment duration when the dose is being increased. Seizures are also reported. The risk is related to dose with an increased risk at dosage greater than 600 milligram. Lowering the dose and adding an anticonvulsant is usually sufficient to prevent seizures. Myocarditis and cardiomyopathies increase mortality in elderly patients with dementia. The side effects are excessive salivation, peripheral anticholinergic effects such as dry mouth, blurred vision, urinary retention, constipation, weight gain, diabetes mellitus, liver function disturbances. Now, when to discontinue clozapine? It should not be done abruptly except for when patient has developed agranulocytosis. Sudden discontinuation leads to severe exacerbation of underlying illness. Cholinergic rebound is possible with symptoms such as nausea and vomiting. So always cross taper from clozapine to another antipsychotic over 2 to 4 weeks. Drug interaction, it shows drug interaction with phenytoin, erythromycin, ketoconazole, because it induces cytochrome 2C and cytochrome 3A4 that reduces the clozapine levels. These are the references.
Good morning, everyone. I am presenting the seminar on Vilazodone, and my moderator is Dr. Ayushi. Vilazodone is a novel dual-acting serotonergic antidepressant that combines with the effect of SSRI with 5-HT1A receptor partial agonist activity. It was approved by FDA for the treatment of adults with major depressive disorder on January 21st, 2011 based on 2 successive phase 3 trials. Its chemical structure is benzofuran carboxamide. Molecular weight is 441.535, designed to have a combined activity as SSRI and 5-HT1A receptor agonist by combining with indole butylamine and cromanonyl piperazine structural element into a single molecular entity. Its pharmacokinetics are dose proportional. Peak concentration occur in 4 to 5 hours after administration. Half-life is 25 hours. Achieves steady state in approximately 3 days. Bioavailability is 72% when administered with food. It is widely distributed and is 96 to 99% protein bound, extensively metabolized with only 1 to 2% recovered unchanged in urine and feces, primary metabolized by cytochrome P3A4 with minor contribution from cytochrome P2 2C19 and 2D6. Pharmacodynamics block the reuptake of serotonin while simultaneously having partial agonist activity at the serotonin 5-HT1A receptor. Due to its dual mechanism of action, it is often referred to as a serotonin partial or reuptake inhibitor. If taken without food, its blood concentration can be reduced by 50% when compared to fed state. Therefore, Vilazodone should be taken with the food. This is the mechanism of action of Vilazodone. Effect of specific organs and system. Vilazodone inhibit the platelet aggregation. Due to the SIADH, hyponatremia can occur with SSRI and SNRI. Therefore, Vilazodone should be discontinued and appropriate medical intervention should be instituted. Therapeutic indication, FDA recommend the indication only for the MDD in adults. However, SSRI and 5-HT1A agonists such as buspirone are FDA approved for the anxiety disorders. Vilazodone may likely to be useful in treating this condition. Adverse effect, GIT, diarrhea, nausea, gastroenteritis, sexual dysfunction, decrease the libido, more common in males, activation of mania and hypomania. In CNS, it can cause dizziness, restlessness, palpitation, tremors, paresthesia, feeling of jitteriness. Sleep can cause insomnia. Vilazodone is classified as pregnancy C category drug. It is not teratogenic and has no effect on fertility. It is supplied in 10, 20, 40 mg tablets. 30-day starter kit is available, which contains 7 10 mg, 7 20 mg tablets, and 16 40 mg tablets. Recommended dose is 40 mg daily. No dose adjustment required for the geriatric, hepatic, or renal impairment patients. It is not FDA approved for the pediatric patients. Drug interaction, when Vilazodone is co-administered with the mouse, it is contraindicated due to the serotonin syndrome. Concurrent use of Vilazodone with NSAID, aspirin, or oral anticoagulant may potentiate the risk of bleeding. It was administered with strong cytochrome P3A4 inhibitor. Those should be reduced to 20 mg per day. And if co-administered with CYP3A4 inducer, those should be increased. These are my references. है ना साइकोफार्माकोलॉजी वाले उसमें से ऐड अच्छा सिर्फ